Hi everybody, Dr. Tim here. Today I'm going to be going over functional blood work analysis. This is going to go over the comprehensive panel that I run in my office, and it's a quick overview. I'm not going to hit everything, but all the things that are pertinent and applicable to most patients are going to be covered today. So there's four sections that the comprehensive test consists of. It's the CBC, or complete blood count with differential, the chem, or metabolic panel, the deflame panel, and then the thyroid panel. The CBC with differential covers your red blood cell count, as well as some other markers that go with it that tell you about the size, shape, and hemoglobin concentration of those red blood cells. And then your white blood cells, it's going to give you a overall count of the total amount of white blood cells, as well as the count of the individual types. So with the red blood cells, we're mainly within a functional medicine practice setting, concerned with anemias as well as B vitamin status. And this is a list of the markers that you're going to be looking at. So the three anemias that we're going to talk about today are iron deficiency anemia, pernicious anemia, which is going to be a B9 or B12 issue, as well as B6 deficiency anemia. So with any anemias, there's going to be symptoms of fatigue, tiredness, things like that, that arise because of an inability for oxygen to be brought to peripheral tissues because it can't bind to red blood cells properly. So whenever you have an anemia, you're going to have low hematocrit, low hemoglobin, and low red blood cells. Whereas because labs are taken, or blood is drawn fasted, it's not uncommon to see these markers elevated due to dehydration. So just think about if you had, 100 fish swimming in 10 gallons of water versus 3 gallons of water. There's going to be a lot more fish in 3 gallons of water. And that's the same thing with these markers. So with these anemias, with your iron deficiency and B6 anemias, your hemoglobin as well as the size of your red blood cells are going to be low, versus with your pernicious anemia, your B9 or B12 anemias, these are going to be elevated. So you're going to expect larger cells on that side. And then I have that little annotated red type there. It says with B6, B9, and B12, you can also see elevated homocysteine, which doesn't sound like a whole lot right now, but we'll get into that later. Onto the white blood cells. So the differential part of the CBC is meant to explain the different types of white blood cells. So if you order just a normal CBC, it'll just give you white blood cells and how many there are, but it doesn't tell you how many of each type. So because we're doing a differential, we'll see that later on, but for now, if you just have your white blood cell count, which also appears on this lab, if you see high white blood cells, you're going to have an acute infection that's present, or if you have low white blood cells, you're going to have a chronic infection. So the five types of white blood cells are neutrophils, lymphocytes, monocytes, eosinophils, and basophils. So those neutrophils, those deal with bacterial and fungal infections, whereas lymphocytes deal with viral infections. And these two different types tend to work in sort of a pendulum, where when neutrophils are high, lymphocytes will be low, and then vice versa. When lymphocytes are high, neutrophils will be low. Monocytes are essentially the cleanup crew that goes in and cleans up anything that's left over from any sort of tissue damage. So any sort of inflammation, gut issues, bladder infections, anything like that, monocytes are going to go in and clean that up. Or if you were to, say, cut your finger or get a bruise, your immune system kicks in there, and your monocytes have to go in and clean up all the damaged cells and all those things. But with leaky gut specifically, you'll see elevated monocytes and then elevated protein as well. Eosinophils, they cover or will elevate whenever there's some sort of, say, seasonal allergies, food sensitivities, things like that. Eosinophils are going to rise, as well as with parasitic infections. Within the practice setting that I operate in, you don't often see basophils as being elevated because they're due to hypersensitivity reactions. And that's going to be like your bee stings or your peanut allergies that cause anaphylaxis. And that's not something that comes into our practice. That is more of an emergency room visit. So the next panel that we're going to cover is the metabolic panel. This thing covers your protein, fat, and carb digestion, as well as some liver markers, kidney markers, your iron that's circulating, and then ions. We're going to touch on a few things that we're not heavily going to cover, but the three big hitters that we're going to talk about today are going to be your protein, your fat, and your carbs. So with protein digestion, protein's digested, absorbed into the bloodstream, and then taken to sites where it can be used. But when protein is broken down throughout the body, it also causes an elevation in the blood. So inflammation due to tissue breakdown is going to cause elevated protein. And this is where that leaky gut comes in with the elevated monocytes as well. If you're not consuming enough protein, you're going to have low protein, which makes sense. But then if you have low stomach acid that's not able to break protein down properly, you could have high protein or low protein on labs. With your fat digestion, there's 4 markers that we really pay attention to. There's a few others, but these are really the big ones. The 4 ones that we're going to cover today are cholesterol, triglycerides, LDL, and HDL. So the things that are going to affect your cholesterol in your labs is going to be a metabolic issue versus a thyroid issue. So metabolic syndrome consists of 5 criteria. Elevated blood pressure is one of them. Elevated resting blood sugar is another. Increased triglycerides, low HDL cholesterol, and then increased waist circumference, which is greater, I believe it's greater than 40 inches with males and then 35 inches with females. And obviously on labs we can't measure your waist circumference, but those are the criteria. The other 4 options you can measure, and you only need 3 to be considered metabolic syndrome. So whenever you have metabolic syndrome, that's basically the Western civilization disease where overconsumption of foods, processed sugars, things like that will drive insulin levels high, and you'll have all kinds of inflammation, risk for heart disease, and it causes you to hold on to cholesterol, triglycerides, LDL, all those things, but at the same time your HDL is going to be low. A lot of people are familiar with your good cholesterol and your bad cholesterol. Your good cholesterol, HDL, takes cholesterol from peripheral tissues in your body and brings it back to the liver where it can be processed and filtered out. Versus your LDL takes your cholesterol from your liver and deposits it in peripheral tissues, including the arteries, where you can get the plaquing of the arteries that puts you at risk for heart disease or heart attack. And so those two things, they kind of combat each other, but when you have higher LDL than HDL, you're depositing more in the peripheral tissues than you are bringing it back to the liver. And so that can be a problem. If you have really high HDL as well as elevated LDL, it's not as big of a problem because the HDL can combat the LDL. But with this hypothyroid pattern, the body tends to hold on to the cholesterol as like a starvation type of currency. So when your thyroid slows down, your body's not going to be able to filter it out as well, and so it really holds on to that cholesterol. So that's why it's elevated. And oftentimes with the hypothyroid, people tend to be trying to be healthy in this situation because they don't feel well and they're trying to get better. And so they don't eat as many fats, and so triglycerides are going to be low. And the same goes with that LDL. It's going to be elevated here. And then HDL can be elevated. It can also be depressed. It all depends on the lifestyle of the person. So the next part of the metabolic panel we're going to cover is your carbohydrate digestion. So in those who are insulin resistant that we just covered before, that tends to go with the metabolic syndrome. So you're going to have your elevated blood glucose, your fasted blood glucose, which is typically going to be over 100. The normal range is 85 to 100, and you'll see that above 100. And then your hemoglobin A1C is a measure of we call it glycosylated glycosylated hemoglobin, and that's where in the bloodstream, glucose will bind to your hemoglobin that's attached to your red blood cells, and it's a more long-term measure of your blood sugar concentration. So that'll be elevated in those patients as well. Now that other thing, dysglycemia is a term that is used to describe fluctuations in blood sugar, and oftentimes it'll mean those people who have lower blood sugar. And so these people tend to rely more on stress hormones rather than insulin. And so that's why resting blood glucose is actually low. It'll tend to be lower than that 85 marker because they're just not eating enough protein and fat to sustain a normal blood sugar. And then with these people, the A1C is typically normal, but it can be elevated as well, and we'll talk about that in a little bit. So, like I talked about before, the patients who rely on insulin, they need it to bring their blood sugar down. And so what insulin does is it takes blood sugar from circulation in your blood and deposits it in cells to lower blood sugar. Whereas cortisol, it takes your stored sugar from cells and puts it back into circulation in like a fight or flight response, because cortisol is a stress hormone. Epinephrine, norepinephrine, those are all going to function the same way. So this image that I've got here, this green line is a really nice, perfect looking blood sugar wave. So at this lower end, your blood sugar should be pretty low to that low end of normal, typically. And then once you eat a good meal, it should come right on up, not reach over 100, and then come right back down by the time you reach your next meal time. And ideally, that should be about 5 hours apart. Your protein and fat that you ingest is going to help get from point A to point B, and then the carbs that you ingest are going to help you get that amplitude towards that 100. You don't need to get that large increase like that in order to sustain yourself between meals, but that's just the ideal. So those patients who are insulin resistant, they tend to have blood sugar that is a little bit higher when they are fasted. And so that's why I have this starting here. And they'll eat something, typically with processed sugars or something that's going to spike their blood sugar higher. And once it reaches over this 100 marker, the pancreas needs to secrete insulin to bring that back down. And so that's what's going to happen there. And over time, these patients who become insulin resistant, they're going to have to bombard their system with insulin because the cells just don't respond to it. And so over time, the resting blood sugar actually sits over 100. And that's where you see the increase in insulin as well as the increase in your A1C. Now, this image is more so for the dysglycemic patients, where they tend to ride the lows with low blood sugar. And these are the ones that have constant stress hormones running, and they're going to feel anxious and trouble sleeping, wake up in the middle of the night, things like that. And so they tend to run lower, so they'll eat, a little bit, but not enough to sustain themselves all the way until the next meal, and then their blood sugar is going to crash, and once they reach under this 85 mark, they're going to have to secrete cortisol to bring it back up into the normal range. So over time, these patients tend to have lower blood sugar that's fasted, and so it'll be below that 85 mark. And another marker that we had talked about, or that we talked about in the metabolic panel, how we're not going to cover everything, your CO2 is a marker that's with your ions. And in this case, with dysglycemic patients, you'll actually see a low CO2 as well as your low fasted glucose. So that's pretty much a dead giveaway for dysglycemia. And then there's another type of dysglycemia that I want to cover today, and that's somebody who experiences both the highs as well as the lows. And when we talked about dysglycemia before, I had said that your A1C can either be normal or elevated, as well as your insulin levels can be a little high as well. And in people like this, what they tend to do is they'll eat something that will cause their blood sugar to rise above that 100 level, meaning that they need to secrete insulin. And then that will bring it all the way back down below that 85 mark where they secrete stress hormones. So you constantly get this up and down between insulin and cortisol, and it's pulling all over the place. Whenever this happens, you're going to see lactate dehydrogenase is going to be low, and that's the only thing that's going to cause that to drop low. That's a liver marker that's also on the metabolic panel, but we're not going to cover the rest of the liver markers. But that's just one that, if you have low LDH in your labs, this is what it's telling you. So the next section we're going to talk about is the deflame section. This should be pretty quick. We're just going to cover vitamin D as well as homocysteine. So vitamin D is involved in immune function and bone health. So if you're always getting sick or you have chronic infections, things like that, low vitamin D is probably your issue. I like to see vitamin D right around 70 on labs, and a lot of people fall pretty well below that. And you can do some pretty high doses of vitamin D to get that back up. And then homocysteine is typically seen, at least in the medical world, as a cardiac risk marker. Um, it's a good assessment of antioxidant status as well as your B vitamins. So homocysteine is the product of running down on your antioxidants that are methionine as well as glutathione. Glutathione is the strongest antioxidant in your body, and the more that you exhaust your glutathione, the more you're going to have a buildup of homocysteine because you just can't keep up with demand. So if you can't recycle your homocysteine back into methionine with the help of B12 and B9, it's going to show up as high homocysteine on labs, but then also it's going to be a good marker or a good indicator that you're not methylating properly. And so that's important for detoxification of like caffeine, histamine, all kinds of toxic substances that are going to be filtered out in your liver. And then another B vitamin that can help get rid of homocysteine is B6. It helps convert it to cysteine, and then cysteine will combine with glycine as well as glutamic acid to become glutathione. So that's why B6, B9, and B12 are so important when it comes to homocysteine status as well as cardiac risk. So the last section that we're going to go over is the thyroid section. And there's 5 markers that are really important. There's a few other ones that we're not going to talk about, but the 5 that we're going to talk about today are thyroid stimulating hormone, or TSH, free T3, free T4, thyroid peroxidase antibodies, and then your thyroglobulin antibodies. So this is the normal path that thyroid hormones are produced through. So your brain secretes TSH, which stimulates your thyroid to produce thyroid hormone. It then enters circulation, and it's able to reach peripheral cells and do work for the body and increase metabolism. One big issue that you'll see a lot of times is autoimmunity. That's where you are in a chronic increased immune state where your body's going to start attacking its own cells. And whenever you have an autoimmune thyroid, that's Hashimoto's thyroiditis. You'll see an increase in TSH because the body's not able to produce, the thyroid isn't able to produce enough thyroid hormone because the immune system is attacking those thyroid peroxidase antibodies as well as the thyroglobulin. It's attacking the thyroid peroxidase as well as the thyroglobulin. So you'll see increase in TSH, low free T3 and T4, and low outputs. You'll feel fatigued and tired all the time. So the next pattern we're going to talk about is a conversion issue. So T4 needs to be converted into T3 in order for it to react with cells and increase metabolism. Whenever you're in periods of high stress or inflammation, it's going to decrease the body's ability to convert T4 to T3. And it can also be as simple as needing zinc or selenium, but more often than not, it's a stress or inflammation issue. And the next pattern that we're going to talk about is the most common subclinical thyroid pattern, and that's where you're going to have decreased TSH due to stress or inflammation. And going back to that blood sugar talk that we had before, if you regulate blood sugar, it's going to alleviate all sorts of stress hormones, and it's going to allow your body to deal with stress better, and meaning that it's going to really help sort this out. You're also going to see in this pattern decreased T4 and T3, and then you're going to feel fatigued just like you will with Hashimoto's. So that wraps it up for today. If you have any questions about what we just talked about, feel free to schedule a 20-minute consultation with me. You can sign up at that link, flourishfwc.jnap.com, or shoot me an email at doc@draugustiniak.com. I look forward to hearing from you, and thanks for listening.